Hello everyone. Today we will begin our discussion on non-steroidal anti-inflammatory drugs, commonly known as NSAIDs. In this session, we will focus in depth on the introduction, classification, and mechanism of action, because these form the conceptual foundation for everything else: uses, adverse effects, and clinical decision making. Let me start with a simple but very important clinical idea. NSAIDs are among the most commonly prescribed and self-medicated drugs worldwide. They are used for pain, fever, and inflammation. However, they are also among the leading causes of drug-induced gastric ulcers, kidney injury, and even cardiovascular events. So, the same drug group can both relieve symptoms and cause serious harm. To understand this dual nature, we must understand prostaglandins. NSAIDs are defined as a group of drugs that produce analgesic, antipyretic, and anti-inflammatory effects primarily by inhibiting the enzyme cyclooxygenase or COX, thereby reducing the synthesis of prostaglandins. Importantly, they do not have steroidal structure and hence are called non-steroidal, differentiating them from glucocorticoids. Now, what are prostaglandins? Prostaglandins are biologically active lipid mediators derived from arachidonic acid. They play a central role not only in inflammation, pain, and fever, but also in maintaining normal physiological functions such as gastric mucosal protection, renal blood flow, and platelet aggregation. This is the key concept. Prostaglandins are both harmful and protective. To understand this better, let us look at the arachidonic acid pathway. When a cell is injured, membrane phospholipids are acted upon by phospholipase A2 to release arachidonic acid. This arachidonic acid is then metabolized by the cyclooxygenase enzyme into prostaglandins, prostacyclin, and thromboxane A2. These mediators have different actions. Prostaglandin A2 is involved in pain and fever, but also protects the gastric mucosa. Prostaglandin causes vasodilation and inhibits platelet aggregation, whereas thromboxane A2 promotes platelet aggregation and vasoconstriction. The cyclooxygenase enzyme exists in different isoforms. COX1 is constitutive, meaning it is present under normal physiological conditions. It is responsible for protective functions, such as maintaining gastric mucosal integrity by stimulating mucus and bicarbonate secretion, preserving renal blood flow, and promoting platelet aggregation through thromboxane production. COX2, on the other hand, is inducible and is produced during inflammation in response to cytokines and other inflammatory stimuli. It is mainly responsible for the production of prostaglandins that mediate pain, fever, and inflammation. There is also a proposed COX3 variant, which is thought to be involved in central prostaglandin synthesis and is believed to be the site of action of drugs like paracetamol, although its clinical relevance is still debated. Now, based on these concepts, NSAIDs can be classified in multiple ways, and understanding classification is extremely important because it predicts both therapeutic effects and adverse effects. First, let us consider classification based on chemical structure. The first group is salicylates, with aspirin being the prototype. Next are propionic acid derivatives such as ibuprofen and naproxen, which are commonly used due to their relatively favorable safety profile. Then we have acetic acid derivatives such as diclofenac and indomethacin, which are potent anti-inflammatory agents but have higher toxicity. Another group is oxycams, such as piroxicam and meloxicam, which have a longer duration of action. Phenamates, such as mefenamic acid, are another group often used in conditions like dysmenorrhea. Finally, there are selective COX2 inhibitors, also known as coxibs, including celecoxib and etoricoxib. Now let us move to classification based on COX selectivity, which is clinically more relevant. NSAIDs can be divided into non-selective COX inhibitors, preferential COX2 inhibitors, and selective COX2 inhibitors. Non-selective NSAIDs such as aspirin, ibuprofen, diclofenac, and indomethacin inhibit both COX1 and COX2. This makes them effective in reducing inflammation, but also leads to inhibition of protective prostaglandins, resulting in adverse effects like gastric ulceration. Preferential COX2 inhibitors, such as meloxicam and etodolac, have a greater affinity for COX2 than COX1, but still inhibit COX1 to some extent. Selective COX2 inhibitors, such as celecoxib and etoricoxib, selectively inhibit COX2 and spare COX1. This results in reduced gastrointestinal toxicity because gastric protection mediated by COX1 is preserved. However, this selectivity also leads to an imbalance between prostacylin and thromboxane, increasing the risk of thrombosis and cardiovascular events. Now let us move to the mechanism of action, which is the most important part of this topic. NSAIDs act by inhibiting the cyclooxygenase enzyme, thereby preventing the conversion of arachidonic acid into prostaglandins. This leads to a decrease in prostaglandin levels in peripheral tissues and in the central nervous system. This reduction in prostaglandins has multiple effects. First, it leads to analgesia. Prostaglandins, especially PGE NSAID2 sensitized nociceptors to pain-producing stimuli such as bradykinin and histamine. By reducing prostaglandins, NSAID decrease this sensitization and reduce pain perception. Second, NSAID produce antipyretic effects. During infection, endogenous pyrogens stimulate the production of prostaglandins in the hypothalamus, which raises the body's temperature set point. NSAID inhibit prostaglandin synthesis in the hypothalamus, thereby lowering the set point and reducing fever. Third, NSAID produce anti-inflammatory effects. Prostaglandins contribute to inflammation by causing vasodilation and increasing vascular permeability. By inhibiting prostaglandin synthesis, NSAID reduce redness, swelling, and edema associated with inflammation. A very important point is that aspirin differs from other NSAIDs in its mechanism. Aspirin irreversibly inhibits the CO-COX enzyme by acetylating it. This is especially important in platelets, which lack a nucleus and cannot synthesize new COX enzyme. As a result, aspirin's antiplatelet effect lasts for the entire lifespan of the platelet, about 7 to 10 days. Other NSAIDs inhibit COX reversibly and therefore have shorter duration of action on platelets. Another important concept is that NSAIDs differ in their selectivity towards COX-1 and COX-2. This selectivity determines their safety profile. Drugs that inhibit COX-1 more are associated with higher gastrointestinal toxicity, while drugs that selectively inhibit COX-2 are associated with higher cardiovascular risk. So to summarize this part, NSAIDs act by inhibiting cyclooxygenase and reducing prostaglandin synthesis. This leads to beneficial effects such as analgesia, antipyresis, and anti-inflammation, but also sets the stage for adverse effects due to loss of protective prostaglandins. If you clearly understand this mechanism and classification, you can easily derive the uses, adverse effects, and contraindications of NSAIDs without memorization. Thank you.